I'm honored to introduce Dr. Vishal Sardhara. Sir is ECMO Program Director and Managing Director of Synergy Groups of Hospital Vadodara. His area of interest is developing develops the make India self-sustain in field of extracorporeal devices. Uh, Over to you, sir.
Welcome to the first ELSACon in India, organized by the Apollo Hospitals. Good evening and welcome you all. Today, we are going to discuss the membrane biology, that is, blood and biomaterial surface interaction in the extracorporeal circuit, especially in the ECMO circuit. So there are certain materials which are being used as the components in the various component of the extracorporeal circuit, which are coming in the contact with the uh, with the with the blood, and that will create some interaction. So that we are going to discuss. So right from the cannula, which is drainage cannula, to the blood tubing, to the centrifugal pump, to the oxygenator, and again to the tubing and the returning cannula. There are various materials which are being used to manufacture the devices. So the pump, which is a centrifugal pump, which contains of the polycarbonate and PET material mostly. Also, there will be some bearings, which may be, according to different companies, it will be like SS or sapphire ceramic bowls as a bearing. And in oxygenator, the short-term oxygenator, which are being made of polypropylene, and long-term oxygenator, now we are using these polymethyl pentene. So those are the fiber for the gas exchange. Then PET fibers also being used as a heat exchange fibers in some oxygenators. They are also using the SS as a heat exchange chamber. And then TPU will be mostly used for the coating of the fibers and making the chamber separate for the gas and blood travel. Also, the epoxy material is being used. ABS also is being used as components, and polycarbonate for the outer shells of the oxygenator. So these are the materials which are being used. All of these materials are having the biocompatibility. They are being biocompatible, but still there are some surface reactions which happens. Also the tubing which is being used is DEHP-free polyvinyl chloride PVC tubings for the various sizes like 3x8, 1x4, 1/2, and 1/16 as per the requirement of the flows. Then the cannula, it contains the TPU and silicone, or like TPU. Surface coating. So these are the coating agents like which will be reducing the interaction between the surface of the biomaterials and the blood. This will be like a mimic, biomimicking, biomimetic factors like phosphoryl choline, heparin, albumin, nitric oxide, polymethoxy, ethyl acrylate, and obviously the blood is also having mononuclear protein, which will be doing the self-endothelialization of the surface within the minutes of starting the ECMO in the patient. So that also like acts as a surface coating. So what happens when the blood meets extracorporeal circuit? So whenever the blood is coming in the contact with the extracorporeal circuit, it can trigger inflammation cascade and coagulation cascades, which leads to the inflammation cascade leads to ulcers. Coagulation cascade leads to shear forces, protein adsorption, and fibrinogen deposition. leading to the coagulopathy, as well as prothrombotic response by the blood towards the extracorporeal circuit. So the sirs, on initiation of ECLS, we see cascades of reaction as the blood passes through the circuit due to surface contacts. These reactions will lead to release numerous chemical mediators, which are also which results in the systemic inflammatory response syndrome, also known as the post-perfusion syndrome. So these are the predisposing factors which will be aggravating the SIRS, so profound hypoxia, and then sepsis and septic shock, and the bacteremia. So how it occurs actually? So blood surface interface, so blood and biological surface interface, plasma proteins are instantly adsorbed within less than 1 second and forms a monolayer of bound proteins. These proteins then undergoes the specific conformational changes and exposes the receptor amino acid groups that are recognized by specific blood cells or plasma proteins such as factor 12, complement protein 3, or platelets. This will lead to the cascade of reaction leading to activation of coagulation and complement cascades and release of various chemical mediators. The physical and chemical composition of the polymer which is being used in the circuit will determine which protein are most likely to adhere to that surface. So mostly the fibrinogen is one of the main protein gets absorbed by most of the artificial surfaces. This release of chemical mediator will lead to the SIRS reaction and usually last for 36 to 48 hours at the initiation of the ECMO or change of the any of the components which will be also known as the new surface to the extracorporeal circuit. So that usually last for the 36 to 48 hours. So pathogenesis of two heat reactions. So ECLS alone results in the moderate inflammatory response. So that is the heat to the reaction. But in the most cases, the two heat reaction, like PMN is primed by the initial stimulus of hypoxia, ischemia, or reperfusion or infection. That is the first hit, and second inflammatory stimulus is given by the ECLS circuit. So that is second hit results in the exaggerated PMN mediated microvascular barrier injury and the edema. The severity of the reaction will depend on the patient's condition before and at the time of starting ECMO and ongoing initial stimuli. The blood-foreign surface interactions initiate these powerful thrombotic and inflammatory response within minutes, which characterized by complements activation and PMN cytokine response. Amplified by release of complement thromboxane and the tumor necrosis alpha factors, so that is TNF alpha. This is followed by PMN degranulation, releasing proteolytic enzymes and oxygen-derived free radicals. This ultimately results in the microvascular barrier damage, edema formation, and tissue injury and organ dysfunction. Altered blood flow also plays the important role in the inflammatory response. So, like if it is VA ECMO, then reduced pulmonary blood flow will be there. So, reduced pulmonary blood flow during CPB and VA ECMO reduces the capillary shear forces, which may increase PMN adherence to the pulmonary vascular endothelium, resulting in the PMN mediated tissue injury. Mucosal ischemia during the normothermic CPB results from the combination of mucosal hypoperfusion and increased interstitial uh, oxygen consumption that is usually due to thromboxane B2 and other vasoconstricting mediators. The inflammatory mediators, which are released and mesenteric via mesenteric lymph nodes, they go through the pulmonary circulation, and these lead to the pulmonary leukosequestration and PMN mediated lung injury. So the precipitating factors, again, the persistent hypoxia, if the hypoxia is for the long time, and then we are initiating the ECMO, the SIRS will be of more in the frequency, or you can say the means it will be like more. Sepsis is also one of the factor, and the endotoxemia. So by increasing the production of pro-inflammatory cytokines, control of initiating, control of inciting stimulus like SEPs. So how we can regulate these factors? So actually, if we want to control the SIRS reaction, then we need to control the inciting stimulus like sepsis or infection. We need to give appropriate antibiotics. So whenever we are initiating the ECMO, usually whatever the antibiogram is there, we actually load the antibiotics at the time to just have that window. Restoration of tissue perfusion and reversal of hypoxia. So once the ECMO goes on, then the tissue perfusion will happen, and hypoxia will be getting reversed. So that will be reducing the SIRS reaction. Then passivation of the foreign surface like ECLS circuit, and as the circuit becomes older, then surface gets coated by the protein. So means initially the passivation is made by these coating agents like phosphoryl So there are two types of agents. One is biomimetic agents like albumin and heparin, and some of the phosphoryl and there are some biopassive agents like nitric oxide surface coating. So which will be reducing the foreign surface response. But again, as the circuit becomes older, then the circuit gets clotted by the mononuclear proteins, which will be acting as a biocompatible surface. So the pacification of foreign surface. Then anti-inflammatory properties of heparin, it will also be the regulatory factor, and self-regulation to limit the inflammatory response. As I said, that the mononuclear protein will get the give the biosurface. So chemical mediators, the cytokines like IL-1 and TNF alpha are the mediators which does these cytokines strong. So TL1 is involved in multiple aspects of the acute inflammatory response, including fever, synthesis of hepatic acute phase proteins, release of growth factors, then losses of body mass, and induces the production of other cytokines, including TNF and the IL-6. TNF also increases the neutrophil aeration, stimulates the neutrophil phagocytosis and degranulation and superoxide production, and enhances the production of other cytokines. So factors controlling the inflammatory response are the passivation of the ECMO circuit, as we discussed earlier. Then we can use the ultrafiltration to control the inflammatory response, like the hemoperfusion is there. Then the steroids, we can use the steroids, and heparin, again, it is going to help us to reduce the SIRS reaction, and we can also induce the hypothermia. The ultra filtration, there has been study which shows that the significant decrease in the IL-6 and IL-8 after the modified ultra filtration, which uh, with more rapid clearance compared to controls. So these are some studies from various uh, people, which is showing that ultrafiltration helps in clearing the IL-6 and IL-8. But there is one thing. It means it also like absorbs the good inflammatory mediators, which can be the drawback in the ultrafiltration. Okay, steroids. So means various opinions are there. Dexamethasone given prior to the CPB or prior to the ECMO uh, is lowering the radiographic lung injury. But again, in view of sepsis or bacteremia, we need to be careful while injecting the steroids. Also, the glucocorticosteroid administration prior to the CPB is also, again, the significant decreasing the IL-6 and increasing the IL-10. So possibly via nuclear factor dependent pathways. So that again reduces the SIRS reaction of the extracorporeal circuits. Also, methylprednisolone has been used prior to the initiation of the extracorporeal life supports to reduce the SIRS reactions. Okay, heparin is it prevents the ODFR mediated cellular injury, and also neutralizes the charge of the platelet aggregating factors. So it will also prevent the platelet aggregations, and it will be happening with the sorry, uh, sorry, heparin neutralizes the charge of platelet aggregating factors with the help of heparin platelet aggregation factors interaction. So it will prevent the platelet aggregation. So with that, we can reduce the coagulopathy. Then hypothermia, reduction in the oxygen consumption, reducing the PM and endothelial adherence, decreasing the release of the ELF selection positive PMN from the bone marrow. The measures to control or the prevent the SIRS on ECMO, like early initiation of ECMO support before predisposing factors like hypoxia, prolonged hypoxemia and ischemia, bacteremia or sepsis or multi-organ failure causing the profound inflammatory response system, eventually the inciting stimulus lasts for the long. So if we initiate the ECMO early, we will be able to control the SIRS as far as possible. Minimizing the circuit length, thereby reducing the total surface area and less exposure. So circuit length, we can reduce the tubing length only. So there is no another thing which we can modify. So tubing length we can reduce so that the total surface area gets less exposure. And use of the coated circuit rather than the regular one. So nowadays all the circuits comes in the coated form only. So mostly they are coated with the heparin, the albumin coating. Timing circuit with the albumin and let it recirculate so that the circuit gets saturated with the albumin, which can lead to the early preservation of the circuit. So this is also one of the measure which we can do while to reduce the SIRS. Use of a single dose steroid just before changing the circuit. So that is going to be helpful. So the conclusion, the SIRS is synonymous with ECLS, and initiation of ECLS always leads to the some degree of SIRS reaction, acts as an amplifier of initial inflammatory response and can exacerbate an already vigorous inflammatory response to sepsis, hypoxia, or reoxygenation and ischemia reperfusion. The elective cardiac procedures usually experience only minor inflammatory response to the ECLS. And there are a lot of studies made to identify the exact mechanism and the factors responsible for SIRS reaction. But still, there are no clear recommendation for anything for chemical implementation as that lacks the randomized controlled trial support. For example, use of coated circuit, dexamethasone, and etc. So mostly the blood and biosurfaces are going to create these cascades, and we need to act according the response of the patient to patient according to condition of the patients. So thank you. Thanks for the